Hello, I'm David Baker. I'm a general surgeon at Freeman Health System, and I'd like to welcome you to the Freeman Bariatric Seminar. This evening we'll discuss the Freeman Bariatric program and get you introduced to all of our comprehensive program and discuss all of the different aspects that you'll go through before encountering and endeavoring bariatric surgery. This is Dr. Coy and I. Dr. Coy and I have been doing bariatric surgery at Freeman Health System since 2013. We have performed almost 700 gastric sleeve surgeries, but we offer a full comprehensive program that includes the gastric sleeve, the lap band, and the gastric bypass. We do say that this is a comprehensive program, and you'll have to meet certain criteria and move through each and every aspect of the program in order to meet the criteria for surgery. It's comprehensive in that we include nutrition, we include psychiatry, we have a support group, and many other aspects that go along with our program, which we think is very important to your long-term success. We can't emphasize enough that this is a lifestyle change, and we really, truly want you to be able to change your lifestyle in order to change your health and be able to move forward, lose the weight, and sustain that for a long period of time. We are accredited through the MBSA QIP. We are the only accredited program in this area. That's a program that will look at all the quality measures in our program and be able to accredit us based on our quality measures and for our comprehensive program. It's very, very important and is a sign of the quality that we provide here. Just a few things about obesity. What is obesity? It's a chronic life-threatening disease. It involves excessive body fat and leads to serious other health conditions. It's an independent risk factor for over 30 other conditions that we call comorbidities. It leads to significant medical, psychological, social, physical, and economic impacts. We know as your weight goes up that all of your medical bills go up. It has tremendous impact on your life as a whole.
Well, welcome to the Freeman Bariatric Seminar. My name's Brad Coy. I'm one of the surgeons, and we're pleased that you've joined us. We'll try to get through some things that we offer here at Freeman as far as weight loss surgery goes. Here again is a slide showing what's considered normal is a BMI under 25. Overweight is 25 to 29. Obese, 30 to 35. Severe obesity, 35 to 39. And morbidly obese is considered a BMI over 40. If you want to know what your BMI is, it's fairly easy to calculate. Take your computer, your phone, and just type in BMI calculator, and it'll ask you your height and your weight, and it'll spew out a number. And that's the number that we go by across the board, so we can speak everybody's language.
This is a body mass index chart. On the left side you'll see the weights, over the top you see the heights, and you see that as the numbers become darker, that's as the BMIs become larger. As you fall into the purple and the red, that's where we start thinking about surgery as being right for you.
A picture of the United States, and you can see in the Midwest we tend to be a little bit more obese. Again, over 30% of the population, and sometimes even down in the lower South, 35% above considered obese. So it's a huge problem that we have in our country. The causes of obesity: inactivity, unhealthy eating, and diets, fast food on every corner, pregnancy, lack of sleep, certain medications, and then certain medical problems will lead to obesity.
What are the comorbidities? We mentioned that before. Other health conditions that are associated with obesity. That's diabetes, stroke, heart disease, high blood pressure, obstructive sleep apnea, osteoarthritis. The list goes on and on. There are more than 30 different of these comorbidities. So what do we do? What are the options? There are commercial diets. We've all heard of the Jenny Craig and the South Beach and the Atkins. What I see is that a lot of these have two things in common. One is that they're very expensive to be involved in, and number two, they're not sustainable. Take the Atkins diet, where you can only eat proteins. You can't eat carbohydrates. You can do that for a period of time, maybe a month, maybe 6 weeks if you really have a lot of willpower. But in the end of it, you have to go back to eating carbohydrates. And when you do, you gain all of the weight back, you rebound, and you may gain even more weight, get past your baseline. So it's really things that aren't sustainable. And that's the whole premise of our program, is that it is sustainable. that you do lose the weight, the comorbidities reduce, and you're able to change your life. Medically supervised diets. Some people are very successful with the medically supervised diets, and that involves a nutrition counselor sitting down with the patient and being able to monitor their eating habits and be able to modify that based on their specific needs. There are a lot of patients who are very successful with that and are able to keep the weight off with the medically supervised diet.
The surgical part that we'll talk about is the gastric sleeve, the banding, the lap band, the Roux-en-Y, and the mini gastric bypass. Who's a candidate for us is someone over the age of 18, usually associated with a BMI over 35 with comorbid problems like we talked about, or a BMI of over 40. We don't do organ transplant surgery, so we limit that population. We want you to be ambulatory because that's part of going through this whole process, is trying to get to where we can get you exercise. And because it is a program, we have you see nutrition and psychiatry before surgery, because not everybody's needs surgery or even a surgery candidate.
So in understanding your digestive tract, this is a slide that goes over the anatomy of what's inside the belly. So on the right side of the patient's abdomen, we have the liver. On the left side, we have the stomach. In the middle there, we have the small intestine. The small intestine is framed by the colon, or the large intestine. As you can see, the liver starts to overlap the stomach somewhat. And when it overlaps the stomach, we see that more commonly in obesity. So as our weight goes up, the size of the liver also enlarges, and it can actually fold completely over the top of the stomach. For that reason, we'll want you to be on a clear liquid diet the entire week before surgery. During that time, when you're on the clear liquids, the liver's size reduces and we're able to manipulate the liver safely in order to do the surgery. If you don't stick to the clear liquid diet, I guess it would be possible to not be able to perform the surgery because of the size of the liver. It would be too dangerous. As we move through these bariatric surgeries, I'd like to point out that there are two different types of bariatric surgery. One is what we call a restrictive surgery. A restrictive surgery is simply where we restrict the amount you can eat. The second type is what we call a malabsorptive surgery, where some of the foods that you eat are not absorbed. So again, there's restrictive that only affects the amount you can eat, doesn't change anything in your digestive tract. And then there are malabsorptive surgeries, where you don't absorb all of the nutrients, specifically fats, and that helps you lose weight. The first surgery we'll talk about is the sleeve gastrectomy. A sleeve gastrectomy is a good example of a restrictive type surgery. This is a surgery that requires a general anesthesia. You make 5 incisions, 1 at the belly button, 4 across the top, and with the use of an automated stapler, we're able to remove 2/3 of the stomach. We completely remove that. That's a permanent surgery that cannot be reversed, and it's restrictive. It reduces the amount you can eat at one time. That, along with diet and exercise, will help you lose weight. Patients are typically in the hospital for about 24 hours after surgery. During that time, we expect the patients to have nausea. We give medications before surgery. We have a regimen of medications after surgery, but typically nausea persists for about 24 hours. As the nausea reduces, we're able to increase the amount you can drink, and once you're able to drink enough to stay hydrated, that's when you can go home. When you go home, you can ride in the car, you can go up and down the stairs, you can drink liquids, and we'll follow a very specific schedule for advancing your diet based on our nutrition guidelines. We wouldn't want patients to lift, push, or pull anything more than 10 pounds for about 2 weeks after surgery. That's to avoid getting a hernia. If you were to get a hernia through one of the incisions, you would require more surgery and then more time of no lifting. The risks of surgery: bleeding, infection, injury to anything in the belly. There's a risk of a leak. Any of those things are possible. They're all very unlikely, and less than 1% of the time would happen. Any of those things that I listed may require more surgery to fix, but again, very, very unlikely. Most patients who have a sleeve gastrectomy can expect about 1 pound per day weight loss within about 30 to 45 days. At about 4 to 6 weeks, you'll reach a plateau. What that means is that your body's resetting your metabolism. Your body realizes that you can't lose a pound per day for 365 days and stay healthy. So when you reach your plateau, your body resets the metabolism. That, along with diet and exercise, will help you to continue to lose weight at a more healthy and safer pace. The pros of a sleeve gastrectomy is that there's no malabsorption. You do absorb everything you eat. It's only restricted in the amount at one time. Patients have a very good amount of weight loss with the sleeve gastrectomy with a very low complication profile. The risk of leak, the risk of infection, the risk of bleeding is very, very unlikely. Patients at 1 year are almost as successful with the sleeve gastrectomy as they are with any of the other surgeries. It's a very good way to lose weight and a very safe way to lose weight. For that reason, we've performed numerous surgeries and patients have been very, very successful.
Next is the adjustable gastric band, or the lap band as people know it. It was one of the first bariatric surgery procedures that was done. I think it lost a little bit of its luster when the sleeve came out. Part of that was maybe our fault as surgeons, as patients would go away, have it done, and wouldn't get the adequate follow-up. It's a procedure that is nice. I think you'll see more of it come back. What we do is we put a band up on the top part of the stomach, and then it's connected to a little port, which you can see in this picture, and that sits underneath the skin in the abdomen, and we can adjust the tightness of the band. We can put fluid in that little band. We can take fluid out, and it kind of restricts the flow of food. It's nice in that you can keep it forever. As long as there's good follow-up, then I think it's a nice tool to have. The weight loss comes in the fact that we want you to get most of your calories through solid food, not liquid food, where some of the other procedures, some of your protein comes from shakes and so forth. Again, pros and cons, everything we do to somebody. The pros, there's no resection of the stomach. Okay, there's minimal malabsorption or iron or mineral or vitamin deficiencies. Again, there's no anastomosis, there's no staple line, no protein calorie malabsorption. The cons, initially less weight loss than a sleeve or a gastric bypass. This is kind of one of those turtle and hare scenario. This is the turtle procedure, so you're not going to lose 100 pounds in 3 months like you may with a gastric bypass or a sleeve. But long term, it can be very efficient if used right. The other cons is it can slip, where the band slips a little bit. Sometimes it has to be removed or readjusted. It can erode, meaning it can migrate inside the stomach. If that's the case, you usually have to take it out. Those are pretty small, i.e. less than 3% typically. The failure, they can rupture. But it can come out, it's put in laparoscopically, it can be taken out laparoscopically. Usually this surgery is done on an outpatient, the patient goes home. With adjustments, we typically would see 4 or 5 times a year, the first year for adjustments, and then kind of tailor it as needed from there.
Roux-en-Y gastric bypass. This is probably the most popular. The most numbers have been performed throughout the country over the longest period of time. And this is a surgery that involves both restriction and malabsorption. The procedure is done under general anesthesia through 5 incisions. A small pouch is made with an electronic or computerized stapler. That's the restrictive part. This pouch is about 1 to 2 ounces in size. And then after the pouch is made, the small intestine is rerouted so that the first part of the small intestine is bypassed. Most of the food and nutrients are absorbed in the first and second portions of the small intestine. Bypassing that part means that the food never reaches those areas, and so less is absorbed. The restriction along with the malabsorption has a very good weight loss profile. The downside to that is that some of the vitamins and minerals that you need for the body to function correctly are not absorbed, and we have to supplement those things either through vitamins or through sometimes injections. Patients are typically in the hospital for about 24 hours. Again, nausea is one of the things that we expect. We do a very good job of treating the nausea, and patients are able to go home within 24 hours once they're able to stay hydrated. We follow very strict guidelines for nutrition, and we have follow-up the week after. Risks for all of these surgeries are very much the same. bleeding, infection, injury to anything in the belly, and then a risk of a leak. Again, all very, very, very unlikely, but anything that happens may require more surgery to fix. Roux-en-Y gastric bypass, again, is a very effective method for weight loss. Probably has the highest weight loss profile, but also has a little higher risk profile. We reserve this procedure for patients who would not be a candidate for either the lap band or the gastric sleeve. Mini gastric bypass. This is a procedure that isn't done very often in the United States. This is something that is considered to be experimental. The part that's mini is that the intestine is routed a little bit different than just the Roux-en-Y gastric bypass. This oftentimes has led to some complications that are very unpleasant. One of those things is called bile reflux. What happens is the food reaches the pouch, it goes directly into the small intestine, and then mixes with bile that is refluxed back into the pouch and can be very, very uncomfortable. Because there are only about 30 surgeons performing this procedure in the country, it is considered to be experimental. The numbers for long-term weight loss, the numbers for malabsorption, and the numbers for malnutrition have not been well studied. And so the insurance companies don't pay for this. It's typically a cash pay situation. Some things to remember about our program that are very important. We wouldn't recommend pregnancy for 12 to 18 months post-operatively. And that's mostly because during that period of time, that's when you're going to have the greatest amount of weight loss. We really want your weight loss to be stable. We want your dietary needs and your nutrition needs to be stable so that you can support a healthy pregnancy. That's very important. Patients are required to stop using any kind of nicotine products for 3 weeks prior to surgery and permanently thereafter. That's very, very important to the healing process. The use of nicotine could lead to an increased risk of leak. If you have a leak, that could require more surgeries to fix. It's very important. Complete abstinence from alcohol for at least 1 year post-operatively. That's for 2 reasons. Alcohol carries a lot of empty calories that really have no other nutritional substance to them at all. And then the second thing is, with losing the weight so quickly, you could actually have liver failure if you're adding alcohol to this. So it's very important not to partake in alcohol. And we oftentimes remind our patients that at some point they may require some or desire some cosmetic surgery after their weight loss. They may have some excessive or redundant skin that would need to be trimmed back in order for them to have proper mobility or range of motion.
My name is Haley Brannon. I am one of the registered dietitians that will be working with the program. I'm going to walk you through just a quick crash course of what you're going to expect as you go through the nutrition with our program. The first thing you'll have with us is an initial appointment. It is about an hour long. You'll meet with a dietitian, and we'll just go through your medical history, health history, all those kinds of things, and really just see where you're at with your weight loss journey. After that, most people usually have to do 3 to 6 months worth of classes. It really depends on your insurance. Classes are 30 minutes once a month, and you'll meet with a group of other people. And we cover a lot of just practical nutrition tips, things you can expect after surgery, just a lot of stuff to try to get you ready for surgery and what to expect after. After that, I've also got a list of things that you can expect to change after surgery. So if you look at the slide here, here is a list of things that we will see and we encourage people to try to work on already ahead of time. So these are your goals you'll be setting throughout classes, things to work on and improve. The first one there is protein first. We emphasize that not because protein is magical food or that it cures everything. We emphasize protein because it's hard to get in and it's really important to maintain that lean body mass. As we lose weight quickly, we also tend to lose muscle, so we emphasize protein to prevent that. You'll also see we have hydration. Hydration is a huge priority. You can only hold about 8 ounces of fluid in your pouch at one time after surgery. So we really emphasize sipping liquids all day long, getting your 64 ounces in a day, and that's stuff that a lot of people have to work on ahead of time. We also, you'll notice up there, we'll say that no fluids with your meals. This is probably the hardest one for a lot of people because it's a volume issue. You'll see, like we keep talking about, that your stomach only holds about 8 ounces. So when we mix food and fluid in there, there's not enough room for all our nutrition and it can cause nausea and bloating. So we really emphasize that. Some other things that we talk about and mention are just basic lifestyle changes. So this is just a tool. The surgery is only going to do so much, right? We also have to change the way we live and the way we eat to help with that. It's going to get you started, but you also have to make some lasting changes to help with that. That includes limiting really high calorie foods. It includes opting for more whole foods, fresh fruits and vegetables, lots of color, lots of variety, basically just a healthy diet. We want you to get those concepts in before as well. We've also got another list of some new habits. These are just some behavioral changes we encourage everyone to start working on already. So chewing food thoroughly, not using straws, avoiding carbonated beverages. And a lot of these things we tell you because it's going to cause discomfort if you do them. Now, it's not just because we're being mean or we don't want you to do them, it's because there is a reason behind that. And we get into a lot more detail on each of these. Another big one is multivitamins. A lot of people don't really take multivitamins or think much about it, but because this is a restrictive and a potentially malabsorptive surgery, depending on which one you're choosing, we do want to fill in the nutrition gaps, which includes a multivitamin and a calcium supplement every day. And again, we get into more detail in that, what to expect, what kind to do, all of those things in our one-on-one appointments.
Hi, my name is Dr. Heather Waitson, and I'm one of the psychologists here with the bariatric team. As far as what to expect for the psychological evaluation portion of the program, you can expect to be contacted by the secretary, and she will get your information and you'll be sent a packet in the mail. And once you get the packet, we encourage you guys to finish all of it and bring it with you to your appointment. The appointment will be about 4 hours long. And when people hear that it's going to be 4 hours long, they're often really turned off by that. You're only going to be spending an hour with either myself or another mental health provider. And after we talk, we're going to be talking about a number of different things. Some of the things we're going to be talking about are listed here on the slides. Mental and emotional status. So we want to know if you're having any depression, anxiety. We're going to talk about your weight, dieting history, as well as your eating behaviors, physical activity, psychological functioning, your coping skills. Sometimes people eat when they're bored or stressed. We might go a little bit into that. We'll talk a little bit about your social support, your knowledge about the weight loss surgery, what your expectations are, and what your goals are for after surgery. So, like I said, we will be scheduling you for a 4-hour block. It says 3 hours there, but we give you 4 hours to complete the entire evaluation. So, when you come in, the whole purpose of this evaluation is to assess your readiness for surgery. Our team really wants to make sure that the patients who go through this are going to be both safe and successful. So we want to be able to identify any risk factors. Risk factors can be multiple different things. Again, we just really want to make sure that all the patients are going to be safe and successful while going through this process. So as far as the process after the evaluation, myself or the other mental health providers, we write the report. We make one of 3 decisions. You can be cleared for surgery. You can be conditionally cleared for surgery, which means that you are able to have surgery, but there are some recommendations to complete prior to moving forward. That may be anything from coming back and visiting with myself or another mental health provider for a couple visits, maybe seeing the dietitian for another visit. It really depends. And the third is being not cleared or denied. And if someone is not cleared, it's usually not a permanent decision. It just means that we've identified some risk factors that might take a longer period of time to address. So when I say longer period of time, that means maybe 6 months to a year. So if we do that, I usually have folks back for a feedback session, let you know how we can go about addressing whatever those recommendations are, because we want you to be safe, we want you to be successful. So if in any way possible, we can help you do those things beforehand, or we can try to refer you to someone else who can help you with those things. That is what we want to do before surgery. Some common questions that we get before having the evaluation, some folks ask, if I'm on antidepressants, can I still have surgery? Yes, we have people all the time who have been treated for anxiety, depression, or other mental health issues, and you can be on antidepressants. We encourage you to also maybe consider therapy if that's something that you haven't considered. There are some, like we had talked about the risk factors. If there's a history of suicide attempts, that's one of the what we call exclusionary criteria. So if someone has had a suicide attempt within the last 12 months, we consider that to be something that causes places a patient at high risk for a negative outcome, meaning that maybe they won't lose as much weight or they might have more distress after surgery. Another common question is about how long it will take to get surgery from the point that after the evaluation. Typically we try to schedule the evaluation close to the end of your nutrition visits. So depending on how many nutrition visits your insurance requires, which might be 1, 3, or 6, you will be able to see once you've completed the psychological evaluation portion and the nutrition portion, then you will move on to see the surgeon, and then depending on that timetable of either their availability or your availability, then you'll move forward. So I can't give anyone a specific timetable, but I will say that the turnaround is pretty quick.
Hi, I'm Janice Drake, the Bariatric Program Coordinator here at Freeman Bariatric Center. After the seminar tonight, a lot of people ask what's the next step, and we want you to fill out the paperwork that is online and submit that, and fill it out as completely as possible. That way when we look at it and we look at your insurance benefits, we can see per your insurance benefits whether or not you are a patient. Whether you have the existing comorbidities and the things that are required to be a patient through our program. After you leave tonight, the copy that we have of your insurance and your driver's license, they will be verified with our insurance department. So you may be getting a separate phone call from them telling you what your out-of-pocket is, your deductible, and what your general benefits require to proceed in the program. And then they will make your first nutrition appointment, and then from there they will call you shortly afterwards to make an appointment for your psychological evaluation. And don't be alarmed if they don't call you immediately for that psychological evaluation, because if you have insurance requirements that are 3 months, 6 months, some are 4 months in nutrition, we just need to get that psychological evaluation done sometime within that time period. But certainly if you're getting to the end of that, don't hesitate to call us. Also, after you clear all of those appointments and you've completed them, that's when you will come see the surgeon, and that's when you'll sit down and discuss which procedure is best for you. If you have a certain procedure that you are interested in, either the lap band, the gastric sleeve, or a gastric bypass, or you've already had a previous surgery, indicate that on your paperwork. If there's not a pre-selected area to write that, just type it in free, and that way we will know what you're kind of more interested in once you come see the doctor. If you have any questions before you get to the doctor, I suggest that you write them down. That way you'll remember when you come, and that way we can be prepared to answer all your questions when you do come in. And from that point, then we send it in to the insurance company for that final verification, and we schedule your surgery. And then you'll be on your weight loss journey.